So
Awesome.
anyway, what I'll do now is I'm going to open it up for questions and answers.
Can you see
and so what I'd like everybody to do, if you have a question or a question, I guess we have the answers, but if you have a question, I'll go ahead and read them. Just go ahead in the question section, type in a question, and we'll go ahead and read them and then answer them. But I've got a question from Ryan here that says, Dr. Yeager, are you able to track your bone regeneration given synthetics can block the view of fusion over time? And I think he's talking about sort of more dense types of synthetics.
Yeah, actually, I've never had to really do that because I'm getting so incredible fusion at such an early time. So I'm very satisfied with the product in terms of that. I really have never had to do that. You know, I hate to sound like too much of a commercial, but like Dr. Mcallister alluded to, I mean, this stuff is getting results quicker than any other product that I've used so far. So no, I haven't.
Okay. I'll ask a question real quick of both of you. In your clinical practice over the course of the years that you've been practicing, can you give us a little rundown of the other bone graft products that you've tried and what your experience has been with some of the different products that are out there?
Yeah, Matt Healy, can you hear me?
Yeah.
Can you hear me?
We can hear you, Jeff.
Oh, okay.
Yeah, he can't answer, but he can hear you.
Okay. Matt Healy had a question that kind of similar. Can you mix it with antique? I think maybe that was meant to say augment. I'm not really sure.
Probably augment.
Probably. So if you want to know your CFO really well, you can mix it with a lot of different things. Oh, antibiotic. Okay. Matt says, Mr. Healy says, can you mix it with antibiotic? I'll let you answer that, Rob.
It's not specifically indicated to be mixed with antibiotic. That's a separate series of studies that have to be done to say that you can mix it. Physically, can you mix stuff into it? Yeah, and have other physicians mixed in vancomycin powder or some other types of things into NanoBone? Sure. I can't attest to the outcomes or the effect, as unless you do controlled studies, you just don't really get the science out of it. Physically, can you put those two components together? Sure. Does it have the effect you're looking for? Quite frankly, we don't know.
And honestly, if you're trying to do a fusion as you are placing an antibiotic in, then why are you doing that? You know, are you assuming it's infected and you're trying to, do a fusion at the same time? I'm not really sure why you would do that. It's not stimulant. It's not cerament. It doesn't serve that purpose. So I think we have to kind of like strategically separate those. But if you're doing it as a prophylactic kind of thing that's off label, I would assume, and it is not a normal foot and ankle procedure to be doing, in my opinion. But so my experience in the realm of bone grafts has been, I've done the standard surgery center BMA, not BMA, DBM. I don't think it works very well. It's cheap. It's cheap feeling. It's like your Target shirt versus your shirt that you would buy at Lululemon. And I don't think that it has as much osteogenic potential. And sure, it goes in and it maybe stays, but I don't think it has the ability to create bone like HA. I've had experience with Augment. I've used Augment for multiple things, ankle fusions, etc. As we all know, there's codes and things for it, but I think that it's different. I think that it's more synthetic than this. I don't think I don't like the granules that are, it's more particulate. So I think that can be a conversation. So it's handleability, as Dr. Yeager said, is different, and it's often mixed with other things. So then it kind of says, well, why are you mixing with why are you having to mix it with other things? So I've played with Augment, the DBM, what else is there? Infuse, obviously. I think we've all played with Infuse. We know that it's super expensive and only indicated in tibial fractures and spine. And so that's typically anytime you use that, it's going to be off label. So I usually, kind of steer clear from it and let my patients know if I'm ever going to use that, it would be completely off label. And but now that these smarter technologies are coming out, I don't think we need to be reaching for that anymore. And then what else is there? So
any experience with stem cell products?
Name one.
Trinity Elite.
Actually, I don't. In residency a little bit, but obviously that's not real life. And no, I would say Jaeger.
Yeah, no. Yeah, and that's cost prohibitive, to be honest with you. And when you asked that question, Paul, I just kept spitting out these on my. I got a little piece of paper here. All these adjectives regarding some of the crappy material that I've used. You've got these, and it is what it is. It crumbles. It spits out. It's not doesn't stay where you want it to stay. I've actually been able to irrigate over the NanoBone, which is huge for me. And going back to utilization of the antibiotic in it, I definitely wouldn't do that, because I agree with you, Jeff. What are we using it for? So I don't want to limit the ability of this product to do what it's supposed to do. And some of the things that are out there in the market, the reps do a very good job and coached very well. I think this product sells itself, and I agree with you 100%, Jeff. Is get them to touch it and feel it, and it's being able to place it where you want to put it and it doesn't flush away, I think is a huge advantage of this product. And so I've utilized everything on the market, and being in the hospital, they're always cost prohibitive in terms of what they want to use and what we can and can't use. And I tell them, and I will go to bat for this, as I'm utilizing this and nothing else. So I like it. It's easy to use. It works, and it's predictable.
Yeah, that's actually one of the arguments that we've been able to make, is that if you have been using maybe combinations of multiple products, you don't need to do that anymore with this product. I know that habits take time to adjust. And I understand, Dr. Mcallister, that you have a comfort level with BMAC. And that's fairly routine when we're having physicians that are switching to fully using NanoBone. It takes some time to have them convince themselves that they get out of our product clinically what the reps promise that they're going to get. Every physician really sells himself on a product based on their own personal experience with it. And their confidence level then develops over time, and they become committed to using a product based on how their patients are doing, quite frankly. And those are steps that physicians have to go through, I think, basically every single time. What we've seen, the product's been on the market now for 3 years or so. And most of the surgeries that have been done sort of historically have been in spine cases. And now we're bridging into some of these other areas that we feel are really nice markets for us to go into, foot and ankle obviously included. We've done quite a bit of stuff in trauma and some orthopedic oncology, mostly spine. One of the interesting things that we found is that physicians that jumped on board early back 3 years ago, to this day, continue to use the product. We don't really tend to lose guys off, sort of wandering off, because they have found that they're not getting a good result. And that's really what sort of will drive physicians' decision making. A lot of times they'll start using a product, and maybe they'll get 6 months to a year into the use of a product, and then they'll become dissatisfied, maybe just somewhat with their clinical outcome, and say, well, I'll try something different now. That has not happened with our product. It's really a testament to where the rubber meets the road, which is good clinical outcome. Yep. So, we're very, very pleased with that. And we have been able to keep the surgeons that we started working with even 3 years ago. They continue to use it to this day. So that's kind of been our progression.
The nice thing that I see is, if you're doing a myriad of different types of cases, like your first case is a TMT fusion, your next case is a revision TTC thing that I was showing. I mean, you can utilize it on different types of cases. And I for most 90% of foot and ankle cases, you don't need more than 5 cc's anything. So, you know, when companies try to say, hey, our only volumes are like 1 for really hand navicular scaphoid kind of fractures, 1 cc, and then the 3s, and then all of a sudden it's like, okay, our next size here, doctor, you're scrubbed in already, and the circulator goes out of the room, and then she comes back with a like 30 cc jug of whatever, chips or something, some dead bone, and it's you're like, okay, I guess I'm supposed to use 30 cc's in this TN joint that Dr. Yeager's doing. This is great, and half of it goes in the trash. So the volume, the thought process between the 2.5 and the 5 is right on with foot and ankle. And I would even contest, you know, the 1 cc may not be a bad option for some guys, or maybe surgery center type environments later down the road. And then I will say that I do, on especially big TTC fusions or something, I will, for volume's sake, I will mix some autograft with it, just to span the whole area. Or if I have like a dusted calc fracture that I'm doing a subtalar joint fusion on, I want to make sure the entire area is covered. But I do think the HA is very natural, and it mixes very well with autograft too. So that's a good kind of selling point for guys that just use autograft and they're stuck on it and they don't want to use any synthetic at all. This is a nice little bridge from the cheap stuff that they might get out of the calc to, from a more volume standpoint. If they are doing those bigger cases, you can add this in to jumpstart your fusion and reduce edema and all the good stuff, and still make them feel comfortable, at least that they're able to get their autograft in 20902 and however else they think about it, if you will. So.
We're down to running out of time. There's one quick question I'll answer before we adjourn, because we're right at 6 o'clock now, California time anyway. The last question on our list is it osteoinductive? Well, that's actually an FDA regulated claim that you have to go and ask for. We've got animal data that suggests that the product is osteoinductive. In different sheep studies, we've shown bone growth in ectopic sites, which is the definition of osteoinductivity. We have data that from these 4 studies that we've done that we feel is something we could present to the FDA and ask for the labeling, but we haven't done that yet. So the answer is no, we don't claim osteoinductivity in the United States. Interestingly, in Europe and in other countries in the world, NanoBone does claim osteoinductivity. So I mean, as a joke, I've had physicians ask me, is it osteoinductive? And I say, well, it is in Europe and Australia, you know, so we can't make that claim here in the US. But anyway, I want to thank you both, and I want to thank all of the attendees today for joining us. I really appreciate you taking time out of your schedules to listen to the presentation and participate. And I once again want to thank Dr. Mcallister and Dr. Yeager for joining us and participating. I think we had a really good webinar today, and I really appreciate your time. Thank you, everybody.
Take care.
Okay, take care. Good night.
Stay safe.